of people over there. Heard some gunshots. A couple people on the ground. I don't know what's going on. Now, shooter's nowhere to be found, but we don't know where he is. So we still want to get those guys to a safe spot. You're in the warm zone for now until the active shooter shows up again.
Hey, help! Arm's pointing out. This guy's pointing out too. He's pointing out his leg.
He needs 2 tourniquets on his leg. One doesn't stop it. If you ever encounter an active shooter situation, that will be one of the most stressful, if not the most stressful event of your entire life. Your fine motor skills will start to fail you, and you will resort back to gross motor skills and the training that you have prior to that time. The skills that we've taught in this class can in some ways quickly be learned, but you need repetition and muscle memory to be able to perform them well under stress. So just because we've concluded our class does not mean your training is over. You need to take these things and practice them over and over until you can do it blindfolded in the dark. These skills and the muscle memory that you create now is what you're going to resort back to if you ever find yourself in a stressful situation where you need to perform these skills. So keep training, keep practicing these things. At the end of the in-person class that we taught, we then practiced a series of scenarios to now take some of the skills we learned and apply them in real-world settings. We had several mass casualty drills with multiple patients in each drill. Sometimes the active shooter had been eliminated, the threat had been eliminated from that scenario. Other times the threat was gone, but people didn't know where it was, so we were still working as if we were in the hot zone trying to provide care for these patients. This was a great time to put into practice being able to determine what phase we're in. Are we in the direct threat care phase where there could still be a threat, or are we in the indirect threat care phase because we know that threat has been eliminated? For the majority of the drills, the potential for a shooter was still present. So we had to provide quick care and then move the patients to safety, to cover, where we could then provide further care to them using the March algorithm. We then practiced some basic patient care transfers, simulating that we are now transferring care to an EMS professional once they've arrived, telling them what care has been provided and what injuries that patient has. If you're running this scenario at home or with some friends, the simplest of scenarios that you can set up is a single patient. That patient is still in an active threat environment. Start with the direct threat care. Have them provide self-aid if possible. If not, get out there and apply a tourniquet quickly and move them to safety when it's safe to do so. Once they're at safety, work your way through the March algorithm. Massive hemorrhage, airway, respirations, circulation, and then head injury and hypothermia. Treat their injuries and keep track of their injuries and what care you've provided, and then during the evac phase, you can then simulate that you are transferring that care to an EMS professional and give them a quick report. Hey, we have a 50-year-old male who has been shot in the chest and the leg. We've applied a tourniquet to the leg. That has stopped the bleeding, and we've got chest seals applied to the chest. Something really simple that now gives that professional a very quick, brief overview of how that patient presented and what you've done for them. So as a quick recap to the class, remember we have 3 different phases of tactical care. We have the direct threat care phase, indirect threat care, and then evac care. In direct threat care, that is when there is still a threat present. We're doing very minimal care here. The only medical care we actually do here is applying tourniquets. The best care we can do in this phase is return fire to eliminate the threat. Also, removing that patient from the hot spot or getting them off the X. If we can move them to safety or they can crawl to safety, that is best. If they can apply their own pressure or apply a tourniquet while we are working to get them to safety, that's preferred as well. In the indirect threat care phase, we're working through our March algorithm once we have that patient to safety. We're behind cover, not just concealment, but cover. We are in a safe environment where we can now work. If we think there still could be a threat at some point, we're going to post a watch and keep someone watching our back as we're providing care for this patient. Work your way through the March algorithm to provide proper care for this patient. In the evac care for a civilian, the main thing we're going to be doing is transferring this care to an EMS professional. In the event that the EMS system is overwhelmed because of this mass casualty, there may be some circumstances where it may be beneficial for you to transport in a private vehicle to the hospital. We've seen this a lot in a lot of mass casualties and active shooter cases where the amount of patients quickly overwhelms the available resources, and people are now having to wait long times for an ambulance ride to the hospital. In these cases, we see a lot of prepared civilians stepping up and providing transport for these patients in private vehicles. We see law enforcement officers using their cruisers as a vehicle now to transport these patients as well. So sometimes you have to do things that are a little unconventional in some of these unconventional settings. Hopefully you'll never find yourself in one of these situations, but if you do, we hope that this video series has helped prepare you a little bit more for this time. Also, remember to keep training and practicing these skills so that if you ever have to use them, you have trained proficiently in them, and that muscle memory can be what you fall back on to be able to provide care for these patients. As always, stay vigilant and stay safe.